Welcome to part 2 of the mental health conditions for adults for the NBCOT exam. If you haven't watched already my video on mental health terminology or even part 1, I highly recommend that you do that and watch that first, as especially the terminology video, this video may contain some terms that you may not have reviewed or not be familiar with. So that'll definitely be helpful. I'll post a link to these in the description. Also, to get the most out of my content, I highly recommend that you not only watch this on YouTube, but also to enroll in my free NBCOT exam course for things like the outlines, the study guides, quizzes, and much, much more. I'm Jeff, the OT Dude, and let's get functional. This video will review conditions that were not covered in part 1 of the adult mental health conditions for the NBCOT exam. The somatoform disorders, eating disorders, and last, substance abuse disorders. And this video will be a little bit special. I will incorporate some quizzes and more critical thinking questions because I know this may be more common knowledge, but the NBCOT may ask differently in special ways and behaviors or how you interact with clients that you should definitely know about. Somatoform disorders can be thought of as a broad group of conditions that are characterized by unexplained symptoms that manifest before age 30. And the root word soma means body, so that probably means something to do with symptoms back in the day when they came up with this term, and probably did not attribute it as much as to psychosocial or psychological etiology, but that's basically the gist of the somatoform disorders. Somatoform disorders may also be classified as voluntary or involuntary. Voluntary meaning intentional, such as someone who is malingering, or involuntary, meaning non-intentional, and it may even be unconscious. Involuntary somatoform, which has more conditions than the voluntary, include the main somatic symptom disorder that was once known as somatization disorder, also illness anxiety disorder, pain disorder, and body dysmorphic disorder. Don't worry, we will go over each and every one of these in great detail for the NBCOT exam. Voluntary somatoform disorders include trying to get a gain of some sort for the symptom or the chief complaint or the illness, such as by malingering or also having factitious disorder. These voluntary ones are commonly thought of as faking the illness, although we don't like to say it in this manner. And I won't go over the OT treatment for necessarily each and every single one of these disorders, as it'll make the video super long, and the treatments really are quite similar. So while it's not necessarily the job of the OT to, say, diagnose clients or patients with a specific somatoform disorder, you may also suspect it though from, say, the patient's history, their behaviors, the way they interact socially, or even the goals they set or what they really want to achieve by being in therapy or under the care of the medical team. An outcome measure that you can use is the screening for somatoform disorders screen. Here's a screenshot of what it looks like. General treatment though includes CBT, cognitive behavioral therapy, which works by helping individuals with somatoform disorders cope with their physical symptoms, reduce their stress levels, and deal with depression and other psychosocial issues. Also, it helps to reduce their preoccupation with the symptoms and to improve their overall quality of life through meaningful occupations. Also, psychodynamic therapy may also show long-term efficacy for improving the quality of life for these individuals with somatoform disorders. OTs may also use strategies to provide long-term management to help manage one's anxiety and stress levels. Let's start with somatoform symptom disorder, which is really what you think of when you think of somatoform disorders broadly. It was basically renamed from the older term somatization disorder from the DSM-4. And it is characterized by an individual who experiences physical bodily symptoms in response to psychological distress. So there is no physical cause, as there may have been like a history done by like a doctor, a history and physical medical tests that are done, such as like x-rays and blood workup and things like that. And collectively, these all do not explain, or there's no like cause or reason for these physical symptoms. There often also may be a history of abuse or adverse childhood events. Certain traumas or life stressors are common with this condition. Certain personality traits also may be an increased risk, such as neuroticism. The criteria in the DSM-5 for somatic symptom disorder is excessive thoughts, feelings, or behaviors related to the somatic symptoms or associated with the health conditions in the three following categories of disproportionate thoughts about the seriousness of one's symptoms, 2, persistently high levels of anxiety about one's health or one's symptoms, and 3, excessive time and energy devoted to these symptoms or concerns. And just FYI, you don't necessarily need to memorize this, but understanding this will help you get an idea of what the disorder is like so that it can be broken down into symptom types for you to understand how we kind of categorize it in the DSM and qualify one for this disorder. For example, there are pain symptoms, GI gastrointestinal symptoms, sexual symptoms such as irregular menstrual cycles, and last, neurological symptoms such as impaired coordination or even paralysis, that is a symptom. Now let's review conversion disorder. You may have heard of conversion disorder, which is also known as functional neurological system disorder, more formally in the DSM-5. I like this longer term more because it has the word neurological in it, so it really describes what this type of condition is, neurological symptoms. And this is quite common from what I've seen in the neuro unit where I work for inpatient acute rehab. For example, we worked with a younger patient who had a history of being diagnosed with multiple sclerosis, but their recent admission to the hospital did not align with their symptoms and chief complaint for multiple sclerosis. Still, of course, we treated this patient as if their symptoms were real. And with this type of involuntary somatoform disorder of neurological etiology, physical symptoms or signs that are present cannot be explained by the medical conditions, such as from the doctor's workup or like an MRI or something, in changes or deterioration in lesions. In other words, physical and sensory problems such as paralysis, numbness, blindness, deafness, or seizures, which are neurological, have no real underlying pathology like the patient has described. And this also implies that it is something else, such as of a psychological etiology. And one distinction between somatic symptom disorder, aka somaticization disorder, and conversion disorder, or the functional neurological one, is that while somatic symptom disorder is characterized by physical symptoms, conversion disorder, once again, is characterized primarily by the neurological symptoms that are front and center. But you will often, in practice or even on the NBCOT exam, maybe see the term conversion disorder, and that's what you should associate with the neurological symptoms. As with neurological conditions, there could, of course, be both motor and sensor deficits, right? So remember to keep this in mind. And what's interesting is that with conversion disorder, it's commonly, although not always, reported by patients who live in rural areas, who have lower socioeconomic status, or have minimal medical knowledge or into the terminology, or just overall healthcare literacy, so to speak. Illness anxiety disorder is characterized by a preoccupation with symptoms, primarily anxiety, as implied in the disorder name. And while there could be other symptoms as well, anxiety for this condition is front and center with illness anxiety disorder. Illness anxiety disorder is also known as hypochondriasis or hypochondria. Chondria is based on the word root chondira, which means cartilage. So hypo means under, right? So hypochondria means under the cartilage, or like the soft tissues and organs beneath the ribs. And kind of the background is that hundreds of years ago, doctors often could not pin down the etiology. They didn't have all these fancy technologies, right, too. So it was these soft tissues and organs which were blamed for these unspecified health problems that the patients were complaining about. And so it took the name of the origin of the body, but we are now suspecting more that it could be psychological too. Pain disorder or persistent pain disorder is pretty self-explanatory, I think. It kind of shifted around like it often does in the DSM, such as from the DSM-4. It was its own disorder, pain disorder, but it is now actually part of the criteria of the first category, the somatic symptom disorder. Pain disorder is often described as predominant pain under the somatic symptom disorder in the DSM-5. But some therapists may still actually call it pain disorder and under that own category. So I left it this way and in this chart so as not to confuse you all. And an example of where pain disorders are commonly seen is, say, in workers' compensation cases. Body dysmorphic disorder is characterized by a preoccupation with a physical defect. While some of us may not, and a lot of us may not like our appearance or parts of our body, people with body dysmorphic disorder think about their real or their perceived flaws for hours on end each day. They cannot control their negative thoughts, and they don't believe people when they tell them, hey, you look fine. So some may go as even far as getting multiple surgeries and to correct their perceived defects in a way to manage their stressors. And there may be emotional distress that can interfere with daily functioning, as you can imagine, if they're so preoccupied with these thoughts. People with body dysmorphic disorder may miss things like work, school, they may avoid social situations, they may isolate themselves. And it can develop in early adolescence and actually affects both men and women equally. You would think it affects women more, but actually they're quite equal. And there's also a higher risk of developing major depression and even having suicidal behavior. So for treatment, I mentioned CBT earlier, but also for this specific condition, exposure and response prevention may also be helpful combined with taking antidepressants. Also, family support is also effective, so family therapy or even group therapy for peers may be helpful. I think for other conditions too, just family support definitely is more likely to lead to success. And like with other conditions, there's an NOS for somatoform disorders, which is for symptoms that do not fit other categories. An example is pseudocyesis, which is really interesting. It's the belief that one is pregnant when they are actually not, perhaps due to signs such as feeling nauseous or having labor pains. Interesting, isn't it? So if you're finding this video helpful so far, please give it a thumbs up right now so you can help other students like yourself find my videos easier. I would also appreciate it if you also shared this with your friends and study groups. You can also support this channel and my content in other ways, becoming a channel member, tipping me in the tip jar, getting some cool OTDUDE designed stickers, t-shirts, or my very own handmade badge reels to wear as a student or at work. These make great gifts too. Links will be in the description. Now back to our content. And you may have also heard of Munchausen. Munchausen syndrome is also known as factitious disorder, the other category in the voluntary somatic disorders. Factitious disorder is characterized by a person appearing sick or producing a physical or mental illness. People with factitious disorder deliberately, i.e. voluntarily, produce symptoms of an illness for the purpose of really receiving care and attention in a medical setting. that sick role. I think there's even a subreddit dedicated to patients, like real world patients or people who fit this condition. So really interesting to check out. And it's like a really cool way to look at all of these case studies and how they behave like on the internet and in real life. And with this category of factitious disorder, the symptoms aren't necessarily intended to get them practical benefits, unlike malingering. So, for example, they may not be after insurance money or a payout or something like that. With factitious disorder, it can be imposed on yourself, oneself, but also on another person. So you may have heard of actually Munchausen's by proxy. The by proxy means that you use somebody else, such as a family member, having their child feign an illness, but they're taking care of them, and maybe they're doing it, maybe feeling important and needed to take care of that child. And there's a really good show that I watch called The Act that is based on actually a true story that depicts Gypsy Rose and ultimately the murder of her mother, Dee Dee, who had that Munchausen by proxy imposed on the daughter, and the mom taking care of her and having her fake things like cancer. And I'm sure you heard of these stories before. So very, very interesting stuff. Those with malingering tend to have more of a secondary gain intention for their condition, such as receiving money. And it's highly likely that you may encounter some of these clients or their families that are doing it by proxy for like pediatrics, definitely in mental health, or even in physical disabilities. All across the spectrum, no matter what setting, it's possible that you may suspect or see a client doing this. Some characteristics of malingering or malingerers include one's manipulation of their medical history, a long history of like symptoms, being involved in a current litigation or threatening to sue, history of being a victim or that victim mentality, risky behaviors, traumatic experiences that has happened to them, such as loss or violence, neglect, or history even of mental illness. And just in general, in terms of behaviors, those with fictitious or malingering may also insist on hospital admission. Instead of like most of us wanting to get discharged, they want to get admitted to the hospital, say from the emergency department. They may ask for a lot of tests and lab tests or treatments or like surgeries, or they may just have a lot of know-how into the medical terminology, be like, hey, what about I don't know, hip replacement, or how about doing this procedure? So that may also be a hint, so to speak. Sometimes we like to call these types of patients frequent flyers too. These individuals may also change physicians frequently and like not be satisfied really with overall care, and especially towards like doctors. And they may also be annoyed with when finding out they have normal findings, when most of us would be, elated to be like, okay, you're fine, you can go home and live your life, Also, they may interact a certain way, such as with urgency or despair when it comes to the condition, when things seem to be just fine. They may be revengeful as well. They may also refuse specifically mental health interventions or not be open to those ideas compared to, say, physical interventions. They may also split the staff with staff splitting. You can also check out my video if you're interested or not familiar with the term staff splitting and the implications for mental health or even phys dis across the spectrum for occupational therapy. You should not necessarily deny their illness or invalidate them or even challenge them through confrontation without much thought in going into it with your team, especially like calling them out on it. But sometimes this actually may be effective. I know I'm contradicting myself, but confrontation may bring relief even for patients who want to abandon that sick role and finally find a way out of it. So if you choose to be confrontational, you should provide supportive confrontation, and that is crucial to the client being able to be open to opportunities for the actual psychotherapy and mental health interventions. So this is kind of client specific when you're asked a question like this on the NBCOT exam, but consider all of these factors and the client holistically and where they are at. And some may want to abandon that sick role, and confronting them may be a way to address that. Other times it may be a trigger and they may just blow you off. So there's no one or right answer, and there's no black and white answer for this. One thing to keep in mind is that if you do decide to confront with confrontation, it should be supportive and never carried out alone by yourself. And definitely you should always document what you do so that patients may, not call you a liar or throw you under the bus, so to speak. So cover your bottom, CYA. According to my research, there is no solid evidence to support the effectiveness of one management strategy over another for voluntary somatoform disorders, as the NBCOT exam likes to ask questions based on how you, the OT, interacts with the client or the family. A general contraindication, things not to do in terms of how you interact, is to avoid being harsh, sarcastic, indignant, or condescending. In the real world, how staff should treat or work with clients is very controversial, as it may be perceived as these people are, wasting time, resources, and staff efforts when other patients with real symptoms need it more. However, OTs should still foster a sense of safety and autonomy with these patients and to follow these OT ethical principles. We don't want to violate these either. And OTs should provide strategies for coping, acceptance, and positive life perspectives. With somatoform disorders overall, you should monitor for suicide ideation, as mentioned, and anxiety, as well as to provide interventions for these stresses and anxieties from things you already learned in OT school, such as using relaxation techniques. Another contraindication is to avoid labeling, such as when you're documenting in your writing for the medical record with phrases such as malingering or, faking, things like that. Now let's move on to eating disorders. And I know you probably know a lot about this condition already, but be sure to stick around this video because the way the NBCOT exam may ask questions can be a little bit tricky. You're probably familiar with the two eating disorders, anorexia nervosa and bulimia. They share some similarities, but also have differences among them. Both are eating disorders and may be marked by lower self-esteem and secretive food behaviors, with a focus on one's weight. Anorexia involves specifically restricting one's intake of food, a fear of gaining weight, and a distorted body image. Bulimia, on the other hand, is characterized by binge eating large amounts of food, maybe grocery shopping and getting more and more food. There may also be compulsive exercising along with that. Also, there may be purging that goes along with that as well, and not holding one's food down. With anorexia, healthcare professionals often rate the severity of that condition by their BMI. More specifically, anorexia may have behaviors such as skipping meals, withdrawing from social opportunities, and struggling in school or work. With bulimia, a significant amount of time may be spent with uncontrollable binging, large amounts of food, and then purging it all out, such as by vomiting, abusing laxatives, fasting, or even excessive exercising. Bulimia can be rated based on the number of purging episodes from mild, 1 to 3 episodes a week, to more of the extreme, 14 or more episodes of purging a week. That's a lot. With anorexia, behaviors include being very focused on one's food and, say, disappearing after meals. And I know I'm jumping back between the anorexia and bulimia, but it's good to be able to contrast and find the similarities between the two. Understanding the effects of both of these conditions is important as an OT so that you can address them based on the client's unique and special needs. For anorexia, they include things like thin bones and lower bone density, thin and brittle nails, yellow skin, new hair growth on the body, constipation, lower body temperature, low energy, menstrual changes, slowed breathing, cardiac issues, cognitive issues, and organ failure in later stages. For bulimia, they may have a sore throat, probably from purging and the stomach acids irritating the lining, and enlarged neck and jaw glands, tooth decay, probably from the purging, GI problems like acid reflux, probably from purging, dehydration, again, probably from purging, and electrolyte imbalance. So you can see how the purging can really be harmful to one's body and one's health. And this can be very, very dangerous, as it can result in things such as a stroke or a heart attack or even death. For OT interventions, one goal is to improve one's health and wellness of those with eating disorders to promote a change in the client, such as their habits and their routines. So a good approach and technique is motivational interviewing, that is client-centered, and it seeks to understand the client and their insight into one's change. Motivational interviewing may be effective because it includes 5 major components that may address motivating factors. And we all know OT motivation is important and crucial too, right? And motivational interviewing is very interesting and promising because they apply 5 principles of 1, empathy, 2, developing discrepancy, 3, avoiding argumentation, 4, rolling with resistance, and 5, supporting self-efficacy. In other words, this basically means to speak the client's language, meet them where they're at, be collaborative, honest, and to be curious for their willingness and their goals for change. And recovery may be promoted with hope, healing, empowerment, and acknowledgement. Another model of practice that may be helpful is the PEOP model, which analyzes the intrinsic and the extrinsic factors that impact one's occupation. For anorexia, something called the Maudsley model, aka family-based therapy, is also widely used. Remember how we talked about how family-based therapy can be effective for somatoform disorders? Well, also applies here for eating disorders. The Maudsley model is actually an intensive outpatient treatment program where the caregivers play an active role and positive role in helping the client, such as their children, with managing their weight for healthier levels. Another goal of this therapy is to prevent hospitalization, rehospitalization, and to aid in one's recovery overall with the medical team. And for bulimia, CBT has been shown to be effective to help the client with identifying things like the flawed thinking patterns with the binging and the purging, their thoughts and their emotions associated with it, and their actual behaviors. So this helps to reduce the behaviors of the binge eating and purging through training and conditioning one's thoughts through that kind of CBT therapy. But of course, we as OTs, how can we address occupations, right? Eating disorders can affect all aspects of life, from meal prep to shopping to work to school to leisure to social relationships, right? And self-care may be disrupted or neglected. They may not tend to things like showering because they're so consumed with the eating part and the shopping part. One may have a lower body weight. They may be hungry all the time. There may be poor nutrition, and it may affect cognitively their attention, their memory, or even their concentration. There may be obsessive thinking and anxiety, such as over which foods to eat, labels, and so on. Also, the over-exercise may leave no room for other activities that are more healthier and more productive. Family meals may be stressful for these individuals, not just for the client too, but also for family, like parents and people preparing these meals. So by using CBT, we can reframe things like exercise and other maladaptive habits into a more healthy manner that is helpful with participation in meaningful activities. You should know that some exercise or activities should probably be avoided due to their high energy needs. So I know as OTs, we often incorporate exercise, but with this population, it may not necessarily be key because they may be overdoing it and it may compromise their health. But of course, be client-centered in your recommendations and their choice, because there is an exercise or a physical activity for everybody that they are still able to do. Here it is an example of how to use the critical thinking to adapt your OT intervention for the NBCOT exam. For example, should you run a cooking group for a group of clients who have specifically eating disorders? Well, would it make the problem worse? Kind of like talking about, say, sexual trauma of a victim of sexual abuse, similar kind of to that. So you may want to consider when this type of thematic group may be appropriate because it can be a trigger for some clients. So while this type of group, this cooking group for this population may not necessarily be contraindicated, clients may need to be warned about it ahead of time to prepare themselves and to reflect on whether they may be able to participate or even tolerate a discussion, especially in a group, and being so vulnerable with such activities that cause them psychological distress in the first place. But they need to address it at one point or another to get over this and to have productive eating and cooking habits and other occupations surrounding food, right? So OTs actually do and often run thematic cooking groups for, say, women with eating disorders with the focus on discussing healthy eating habits. Then, say, each week, the OT may provide a theme for a habit, such as journaling their thoughts, such as with CPT, surrounding these occupations to complete, say, an actual recipe of their choice that balances nutrition and health in a real setting or a simulated setting. And so there, like I said, is no one-size-fits-all answer. And if you're asked this on the NBCOT exam, I think consider what you are given in the prompt and then use your critical thinking and go from there to find the answer, that best answer that makes the most sense for that individual client and where they're at, given the information in the prompt. Let's do another one. Another scenario is an OT who works in an inpatient program for patients with eating disorders. The OT is running a social skills group this time, but one of the members does not participate in the discussions because of that larger group format. What should you do? Should you exclude the client from the group? Would you change the group format overall? Or would you change the topic? But on the other hand, the rest of the clients would benefit from working on these social skills in a group. So the answer is it would be appropriate for the OT to plan the next scheduled group session into smaller groups in order for the clients to still engage in these group discussions surrounding the social skills, but in a smaller format so that it may not necessarily cause anxiety for everyone, not even just that one client, but other clients may also have anxiety with it as well. So this is meeting the client where they're at and changing your intervention and adjusting it accordingly. This example and how to answer this situation shows what the NBCOT expects you to demonstrate in terms of the competency to demonstrate one's knowledge to continually reassess the intervention and modify it accordingly to promote successful outcomes. Last, let's review substance abuse disorders. It's important to understand that substance abuse can affect anyone across all backgrounds, ethnicities, locations where they're from, cultures, conditions, even ages, and not just specific groups such as, say, the homeless, for example. You know, I saw a post online that was very insightful. It said, most of us are probably closer to becoming homeless than we are to becoming millionaires. So, you know, to treat everyone, especially like the homeless and those types of populations that are marginalized, with respect and have empathy for them, because it could easily happen to you, right? So again, it is important to approach it from a holistic perspective and to be client-centered and not just hone in on the disorder itself from like a bottom-up perspective, and to think about it from the family, the finances, one's habits, their roles, routines, their strengths, barriers, meaningful occupations, what their goals are, things like that. Again, there's no one size fits all, again, for this condition either, as one person may be different, and what may work for one patient may not necessarily work for another. There's no cookie cutter approach. Although we do have things like 12-step programs, with OT, we tend to be more holistic and to have them engage in all occupations based on roots of our profession. To give an example, I recently heard of a social worker that had a son be admitted to the hospital for substance abuse. So you would think, right, wouldn't this not be the case? Someone who works in the field, who's a case manager, who works with clients who, you know, have substance abuse all the time, their actual son has that condition. But you don't know this family's story and this client's story or their struggles. So that's just, again, highlights how to try not to be biased. So it's important to look at things with a fresh, non-judgmental eyes, and to, again, remember the OT code of ethics and to apply a client-centered or family-centered approach. And I think that's best. Intervention methods for substance abuse include brief interventions, CBT, motivational strategies, and 12-step treatment programs. And I have seen some clients even use these in a combination too. For example, in my fieldwork, there were clients attending an outpatient CBT program who were also part of 12-step programs as well. So intuitively, I think this would probably be more effective, even as these clients are receiving more therapy, more education, more support, more reinforcement for healthier habits, and helping them prevent that relapse into slip, and to help them engage with their peers through that additional social support. Not just like us as a therapist, but talking to somebody else who's gone through it and they saw the light at the end of the tunnel and they're on the other side can be very powerful. And more treatment and more support, the better. So I wouldn't say one treatment is necessarily the key, but they may use it in conjunction. What brief interventions are they're short sessions from say 5 minutes to an hour long that have several sessions with a focus on investigating that potential problem and to motivate the client to do something about their substance abuse. So some problem solving and some gaining insight into it. This includes providing feedback, benefits of education for the healthy lifestyle changes, and advice that is really just client directed through change. CBT, we all know, and it would focus on the healthier coping behaviors and to reduce the relapse. We reviewed motivational interviewing as from earlier, and that may help as well, but also other approaches that you may not have heard of may help too, including things like decisional balancing and motivational enhancement therapy. I wouldn't necessarily worry about memorizing this, but if you see some kind of decision-making or motivational thing, it may help the client. And these are less traditional than CBT, but they have been effective in the research, so you should know about it. Decisional balance exercises, they help to explore the pros and cons of, say, drinking and using drugs to help them gain insight and come to a conclusion that it's probably in their own best interest to cut down on those substances. Motivational enhancement therapy, it's a protocol that considers change, but also it strengthens the actual change process after the consideration and the actual change part. 12-step programs like Alcoholics Anonymous, they're very popular and they can be very helpful as well to provide that peer support and the fellowship with that one day at a time motto. With regards to peer support, someone who attends a 12-step program may also have a sponsor that helps them work through it, that they can call or text at any time. And one can also serve as a sponsor for their peers as well. And in terms of outcome measures, some psychometrically validated measures are based on 1, the cravings, and 2, improving one's quality of life, such as the craving questionnaire based on the specific substance in question, like drinking or cannabis or something, and the short form 36, the SF36, also the WHO's World Health Organization's quality of life outcome measure. Here's a scenario for the NBCOT for you to consider. A college student was admitted to the hospital for overdosing on drugs from an underground rave. The client states that one of their goals is to improve their grades so that they're able to graduate from college and to get a job. So, what area do you think as an OT is important to evaluate and to assess when working with this client? Is it ADLs? Is it school and education? Or is it leisure skills? I'll give you some time to think about it. If you chose leisure skills, then that would be the best answer. You may be tempted to choose academic skills, and that is because that's the stated goal of the client, but the question asks what areas should be evaluated further. And with substance abuse, it's likely that that client has no real healthy ways to manage their leisurely time, their free time. So they may be doing more drugs or participating in these raves. So they may resort to these substances when they're bored. So exploring this area would help the client find healthier ways for managing their leisure and to avoid further risks, such as overdosing in the future, which could be very serious, right? It can lead to one's death. So that's a safety thing. So although its client stated that the goal is important to address school, you have to look at them holistically and what brought them to the hospital in the first place. By addressing their leisure skills and that drug issue, you kind of also kill two birds with one stone, right? You affect school because they may find healthier ways to spend their leisurely time. And because they're doing things more productively, they may not be like high all the time. Their grades may not suffer because they are not altered by drugs all the time, by being sober. Secondarily, you can then also evaluate school and education, but this should not take as much time either because you probably know that their grades are not doing so well because they said so. So you don't really need to further evaluate it. Like, oh, what are your study habits like? Well, they probably can't study because they're not sober. What about ADLs then? I think this one is just a distractor. It's not a stated area of concern based on the question prompt and the information we're given necessarily for the client. Now's a good time to give this video a thumbs up and to check out this topic's quiz on the free NBCOT exam prep course for more questions to quiz your knowledge on these concepts and this content. The link will be in the description.